Good afternoon, everybody. My name is Nick Barker. I'm a clinical pharmacy coordinator at Emory St. Joseph Hospital in Atlanta, Georgia. I run our bite-sized lecture series. I'm excited to introduce our panelists today, but first let's read our mission statement, which is to emulate SECM's mission, which is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. It's my pleasure to introduce a couple of different panelists from the University of Alabama at Birmingham today. Dr. William Rushton, who's the medical director of the Alabama Poison Information Center at Children's of Alabama, as well as the director of the Office of Medical Toxicology at University of Alabama, Birmingham. Jessica Rivera Pescatori, who's a clinical pharmacist in the emergency department at the University of Alabama at Birmingham, and Tim Lewis, who's a clinical pharmacist for cardiothoracic surgery and mechanical circulatory support at the University of Alabama at Birmingham. They're going to be presenting today on New Frontiers, ECMO Utility and Calcium Channel Antagonist Toxicity. At this time, I'm going to let them take it away.
Thanks so much, Nick. We appreciate that wonderful introduction, and thanks to everyone for logging on. We really appreciate your time, and we are very excited to be with you today and to talk about a very interesting and timely topic. So before we really dive in, I'd love to just take a brief moment to briefly review calcium channel blocker toxicity. This is an important topic because cardiovascular drugs are not only a common cause of poisoning, but are also an increasing cause of poisoning, resulting in significant morbidity and mortality. Most recently, cardiovascular drugs represented the 6th most common reason for a call to U.S. poison centers, and consistently they fall within the top 10 most common cause of fatal poisonings, according to the National Poison Data System. The majority of fatalities are actually linked to the calcium channel blocker group. And while verapamil has historically been the most dangerous agent, or kind of our scariest agent, we have observed an interesting and particularly challenging shift in epidemiology recently. Amlodipine is actually now the most prescribed calcium channel blocker, and fatalities are increasing, outnumbering other agents. So this has somewhat shifted our landscape in a way and forced many clinicians to somewhat reassess their approach to calcium channel blocker toxicity by exploring additional treatment modalities. So as we know, calcium channel blockers exert their therapeutic effects by directly inhibiting the influx of calcium at L-type calcium channels. Functionally, they are divided into 2 broad categories or groups. The non-dihydropyridines, as we know, primarily work by inhibiting calcium channels within myocardial cells, whereas dihydropyridines exert their effects through preferential binding to calcium channels found peripherally within the vascular smooth muscle. Now, in an overdose situation, particularly with massive ingestions, this preferential binding is largely lost and can lead to varying degrees of antagonism of calcium channels within the body, particularly myocardial cells, on smooth muscle, and in an often forgotten about location within the beta islet cells of the pancreas. And so these resultant decreases in cardiac conduction, cardiac contractility, and systemic vascular resistance are thus further complicated by the prevention of insulin release from the pancreas, leading to hyperglycemia and hypoinsulinemia. And this is really important to highlight, as during a stressed state, such as one that would be induced by calcium channel blocker overdose and the shock that results, the myocardium will actually shift its preferred energy source from fatty acids to carbohydrates. However, with no insulin available to actively transport glucose into cells, the heart is really unable to meet metabolic demands, and this further potentiates cardiotoxicity. So ultimately, these effects will culminate into cardiogenic shock, distributive or vasodilatory shock, or really some combination of the two. Profound hypotension and bradycardia with varying degrees of AV block are typically at the forefront of symptomatology. And making matters worse, metabolic acidosis will develop systemically due to the overall decrease in tissue perfusion, and pulmonary edema develops due to precapillary vasodilation and increased transcapillary hydrostatic pressure. And as we are all well aware, as acute care clinicians, these sequelae can be really tough to overcome, particularly during our kind of initial resuscitation phase. So that kind of segues us into the standard approach to treatment of these patients. Now, patients with life-threatening intoxication will require multiple therapeutic interventions, both pharmacologically and non-pharmacologically, perhaps. In addition to supportive care, some immediate interventions are going to include fluids, atropine, calcium, and adrenergic agents. Unfortunately, these interventions may not necessarily improve hemodynamic parameters or ensure survival in our very severely intoxicated patients. Furthermore, they really have varying degrees of success from patient to patient. So it can be hard to standardize some of these approaches. Now, intravenous fluids and calcium are, of course, usually the first drugs that are going to be readily available for administration and kind of reached for. But as I've already alluded to, these are really going to provide varying and often very short-lived effects when treating hypotension and conduction disturbances that are resulting from calcium channel blocker toxicity. Being conservative with our IV crystalloids is an important consideration within this context, as again, these patients are likely to receive really high volumes from multiple agents, and they can quickly become volume overloaded, further complicating things. Catecholamines or adrenergic agents can increase blood pressure and heart rate, but they also increase systemic vascular resistance. And while this is a desired effect, the subsequent increases in afterload may result in decreases in cardiac output, which can worsen organ function. I think we are all too familiar with the balancing act that this becomes, but especially in cases of poor left ventricular function, as can be seen with calcium channel blocker toxicity, it's even more prudent to consider this and really should dictate your agent of choice. We are typically reaching for norepinephrine and or epinephrine early on with the addition of other agents as the course progresses, or while we are working to initiate other therapies that might take a little more time, such as high-dose insulin. Now, literature primarily supports the use of high-dose insulin for calcium channel blocker toxicity. Research in several canine models by Jeff Klein and others shows us that compared to standard treatments such as calcium, glucagon, or catecholamines, high-dose insulin is most effective at improving survival. We've also learned from these models that insulin works through at least 4 main mechanisms. At these extremely high doses, usually starting with a bolus dose of 1 unit per kilo, followed by an infusion within a range of 1 to 10 units per kilo per hour, insulin is acting as a potent inotrope to help increase cardiac output. It also optimizes myocardial energy utilization of carbohydrates and helps to improve the resultant hyperglycemia that we see from the poisoning itself. And lastly, it acts as a vasodilator through its effects on the nitric oxide system, treating microvascular dysfunction, which we know is a hallmark of cardiogenic shock. And this is an important mechanism to think through, as vasodilation might seem a little counterintuitive. And while this is certainly helpful in improving perfusion in cardiogenic shock and maintaining end organ function, it could become a little more tricky when we're dealing with a pure vasodilatory shock. So it is important not just to think about the agent at hand, but also thinking of high-dose insulin purely as an inotrope that may not significantly improve your vital signs, but instead really be monitored through the signs of perfusion, such as urine output, serum lactate, or even capillary refill, for example. Utilizing bedside ultrasound may also help when deciding if this therapy is actually warranted, and should only really be initiated if cardiac contractility is impaired, knowing these mechanisms. Now, if high-dose insulin is in fact necessary, it's important to not take this therapy lightly, despite how supported it is by evidence. For those of us who have experience with high-dose insulin, we know just how labor and resource intensive it can be. It certainly requires adequate education of all care team members and aggressive monitoring of not just our hemodynamic parameters, but also glucose and electrolytes. Ideally, it should really be performed per established guidelines or protocols to help with safe execution. At our institution, we have developed an electronic order set and a smart pump setting for a very concentrated regular insulin infusion that is specific for this indication. And now, despite aggressive resuscitation with these agents and the possible synergy that may occur amongst them, some patients will still require adjunct therapies. Often we will reach for nitric oxide scavenging agents such as methylene blue, particularly when profound vasodilatory shock is ongoing or if amlodipine is the agent involved, which these days seems to be all the time. And that's because amlodipine can actually produce further vasodilation through its effects on nitric oxide. More invasive measures such as transcutaneous or even transvenous pacing may be required. And with severely intoxicated patients, the consideration of rescue therapies such as intravenous lipid emulsion or ECMO are of course important. And so this is really a good time to segue into a review of a patient case. And so I'm going to turn it over to Dr. Will Rushton so he can kind of walk us through a challenging case we recently encountered.
Thanks, Jess. That was great. And you know, I feel so passionately about these cases because these calcium channel blocker cases are just notoriously difficult to treat. And there's all these new therapies are coming out. The literature is sort of all over the place with different recommendations and different types of shock. And I love that we've been invited to talk about this because one thing I feel so passionately about is when it comes to treat these very complicated sort of toxicities, it's absolutely a multidisciplinary sort of approach that goes along with it. This is actually a different amlodipine case that we took care of a couple of years ago when we were giving lipids and I think hydroxycobalamin and high-dose insulin. And really, I think afterwards, you know, after this very aggressive several hours resuscitation, sort of felt like we were Marvel superheroes and decided to send you guys or share with you guys a pose of all us doing this. But I'm gonna get in the case now, but it's just, I cannot emphasize much of sort of the wealth of people's background, and everyone has all these great insights to bring into it. I'm gonna talk about the case, but as I look actually at the audience, I see actually a lot of the pediatric intensivists that actually took care of this are in the audience here too. So I wanna absolutely make sure that I give them a shout out for some of the great care that happened with this. But this is actually a 12-year-old female that actually showed up to the emergency department with 2 days of really nausea and vomiting. And initially, it was very unclear exactly what the etiology of her presentation was. Showed up here, you know, obviously in sort of a shock-like state, sinus tachycardia to 120, had initially sort of profound hypoxia. And on the chest X-ray upon admission, again, 48 hours in the symptoms, you know, was known to have these sort of bibasal or pulmonary infiltrates. A point of care cardiac ultrasound was done, and there was maybe some mild left ventricular dysfunction. And ultimately, due to sort of progressive sort of hypoxia, got admitted to the pediatric ICU on high flow nasal cannula. And at this point, is sort of the presumptive thought was, you know, this is probably sepsis of pulmonary origin. I think those of us just do a lot of emergency and critical care medicine. It's sort of the mantra, it's always sepsis. And that's certainly, you know, what she was being very aggressively treated with at this point. But really over the next 24 hours, it's just had this sort of persistent decline despite very aggressive resuscitation techniques. Came in with a lactate of 10. And interesting enough about this lactate is over the course of the next 24 hours, actually titrated down to 2 millimoles per liter despite a persistent sort of shock-like state. Sort of got rapidly titrated up on vasopressors, got put on epinephrine, then got put on vasopressin. Now, about 12 hours after ED arrival, had a repeat point of care cardiac ultrasound. At this point was noted to be a very hyperdynamic left ventricular function. And the glucoses were also sort of persistently elevated in sort of the low 200s, no history of diabetes. Still with the thought that this is most likely sort of, you know, refractory sepsis of a, you know, pulmonary source is the ECMO consult service was called. And initially here, I think deferred and made the recommendations just to continue with, you know, again, very aggressive sepsis management. But really over, you know, about 24 hours sort of again after ED arrival, 3 days in symptoms, just this persistent and refractory hypoxia ultimately developed respiratory failure and had to be endotracheal intubated, placed in mechanical ventilation, and paralyzed. And was very impressive, I think, at this point, now 24 hours into it, is even though we have a very aggressive sort of left ventricular function seen on point of care cardiac ultrasound, is start showing signs of just sort of severe anasarca. Not only had a significant amount of tibia edema, but also sort of impressive amounts of periorbital edema as well. And these physical exam signs were also, coordinating to other signs of end organ dysfunction, persistently with her renal dysfunction. She was actually sort of starting to develop oliguric renal failure. Renal output or urine output had sort of dropped precipitously. At this point, I think a lot of people are sort of, trying to take a step back and ask themselves, what are we missing? What other therapies? Is it still, again, a presumed sepsis case? What's the next step? Is there still a role for ECMO? And we're going to come back to this case and try to, so you can see how it sort of ties back in, obviously, to calcium channel blockers. But before we come back to the case, I think as Tim Lewis is going to talk to us really about some of the mechanics of ECMO, because I actually learned so much about it during the course of this case.
Awesome. Thanks, Will, for introducing. So in 2017, the Society of Critical Care Medicine published expert consensus guidelines in adults for treatment of calcium channel blocker poisoning. These guidelines were endorsed by the Society of Critical Care Medicine, by the European Society of Intensive Care Medicine, American College of Medical Toxicology, American Association of Poison Control Centers, amongst many other organizations, lending support for treatment algorithm for calcium channel blocker overdose. You can see the treatment algorithm that they proposed in the chart on your right here. As Jess walked through kind of standard treatment approach for these cases, you can see the boxes listed here. Specifically in the highlighted blue box down below, you can see rescue treatment, including a recommendation for VA ECMO consideration, and then in a cardiac arrest situation as well, consideration for VA ECMO cannulation in the setting of somebody who's actively arrested or in an ECLS sort of setting. So these guidelines give a fairly low level of recommendation based on low quality of evidence, but still did make it into the guidelines here. I think it's a little bit important for us to understand the mechanism of what ECMO is actually accomplishing before we move further and why we would use it though. So I'd like to talk a little bit about that. The figure on your left, sorry, it's taking a second to load for me. The figure on your left is going to display VV ECMO. So VV ECMO is used in a patient who has respiratory failure, most commonly outside of a toxicologic emergency situation. This would be used for a patient with ARDS, for example. This would be used to support the respiratory system and act as a sort of artificial lung outside of the body. So you can see in the image here that blood is being drained from the inferior vena cava into one cannula, pulled from the body and then to an external circuit. A pump outside of the body creates negative pressure to pull blood from the venous system, then goes through an oxygenator, which will exchange gas, remove CO2, and oxygenate blood independently of each other, with the ability to adjust titration of those parameters independently of each other, and then return blood that has had CO2 removed and been oxygenated back to the right side of the heart. In this example, through a right IJ cannula here. This would then go through the normal path of circulation through the heart, still through the lungs. In the example of VV ECMO, the lungs should hopefully not have to do a whole lot of work if ECMO is working properly with adequate flow, because gas exchange has largely already taken place for blood that's gone through the ECMO circuit. This does require a functional circulatory system though. So as blood moves into the right side of the heart, the right ventricle must work properly. As blood moves then to the left side of the heart, the left ventricle must work properly to act as the pump for the circulatory system, and to be able to move blood through the body to ensure adequate oxygen delivery. On the right side of the screen, you can see an example of VA ECMO. This would be termed peripheral VA ECMO. In this example, this would be pulling from a vein, returning to an artery. So here you can see that blood is being drained from the inferior vena cava through a cannula that's present there. Again, goes external to the body, extracorporeally, has gas exchange take place through an oxygenator, removal of CO2, oxygenation of blood, and then return to the femoral artery. With this path of circulation outside of the body and return to the femoral artery, in this peripheral VA ECMO cannulation, blood would actually be going retrograde to normal flow of blood. So blood would actually be going up the descending aorta rather than down the descending aorta, as what would occur in a normal circulatory system. This retrograde flow of blood will then, in the case of severe myocardial dysfunction, will be responsible primarily for oxygenating and delivering oxygen to end organs, including the brain, head, neck, etc. As the LV starts to recover from a myocardial injury, and then this will shift blood, and there will be created a mixing cloud where blood that's being injected from the native circulation, the native LV, meets resistance against blood that's coming from the ECMO circuit. And then certainly many considerations for how to manage a patient with a mixing cloud that's shifting. VA ECMO would be used primarily for cardiogenic shock with or without respiratory failure. So for use of ECMO in poisoning, the primary goal of ECMO is really to provide circulatory and or respiratory therapy support as a temporizing measure. It's not a treatment in and of itself per se to treat the underlying poisoning, but is ensuring that adequate perfusion and oxygen delivery is able to occur to hopefully facilitate recovery from end organ damage and support the circulatory system in that effort. So eventually, as drug is cleared or an antidote provided, then the hope would be that the body is able to recover on its own, or if end organ recovery is not feasible, then potentially transplantation, if appropriate for the patient. I've listed a couple different examples of forms of drug toxicity that could be used for different forms of ECMO. This is certainly not all-encompassing and does not limit ECMO support in each category to that specific toxicity. It can be very dependent on how the patient presents and what their symptoms are at presentation that would determine a potential role for either VV or VA ECMO. Again, I'll reemphasize for VV ECMO, this would be used really just to support the lungs. It's going to rely on a functioning circulatory system and functioning myocardium to be able to act as the body's pump for delivering oxygen. There are a couple listed examples there. Again, for VA ECMO, this would be hemodynamic support in the setting of a poisoned patient with refractory cardiogenic shock, or in the case of ECPR, a patient who arrests and then is put on ECMO as a form of circulatory support in the midst of an arresting patient. The most common use for this would be in cardiovascular agents such as beta blockers, as we're talking about today, calcium channel blockers, or antiarrhythmics. There are also a couple situations where there may be either respiratory or circulatory dysfunction, myocardial dysfunction, but that the role of ECMO is not well established or could be contraindicated to use ECMO. A couple of those are irreversible end organ damage, especially if it's multi-organ failure that's deemed to not be likely reversible, or single organ failure if a patient is not going to be a candidate for either heart or lung transplantation. This would be the case for things like caustic ingestion or radioisotopes. Another toxicity would be cyanide toxicity, where there's mitochondrial failure, where ECMO support would not be likely to provide adequate support to be able to get through the mitochondrial toxicity that occurs. Also situations where there's ineffective oxygen delivery or an ineffective ability to transport oxygen in the circulatory system. Such would be the case of massive methemoglobinemia or hemolysis, where despite circulatory support from an external circuit and cardiac support, there's an impairment in tissue to be able to extract oxygen from blood that's passing by that tissue. ECMO has a higher incidence of bleeding and comes with a risk of bleeding. Anticoagulation is commonly used for ECMO support, though not every patient will require anticoagulation while on ECMO. But severe coagulopathy or active bleeding would be considered relative contraindications to ECMO support. The next slide will display ECMO utilization over time. So this is data from the National Poison Data System from 2000 to 2018 with cases that reported ECMO utilization. And you can see the trend in ECMO use over time gradually increasing in more recent years. On the left-hand y-axis, you can see the number of ECMO cases that were for drug toxicities, and these correspond to the bars on the x-axis here. And so you can see the light blue bars represent pediatric patients who survived their ECMO run to discharge. Dark blue is pediatric patients who did not survive, light red, adult patients who survived, and then dark red, adult patients who did not survive to discharge. So as you can see, obviously, again, the incidence of ECMO utilization has increased over time over the last 20 years or so. On the right side of the screen, in the y-axis is mortality, and that's corresponds to the dotted lines across the screen, showing mortality in that year for patients who used ECMO as part of their circulatory support. In the last year here in the graph, 2018, there was 98 cases that used ECMO in support of a drug toxicity. More recent data, the most recent data comes from 2021, and there were 127 cases that used ECMO. So you can see that that trend continues to increase, and I would predict and imagine that that will continue to be the trend. The ECMO will be further and further utilized more in the case of drug toxicity in the future. The next slide is a continuation from the previous graph that I displayed. This is a study using NPDS reported data. Unfortunately, NPDS does not report whether VV or VA ECMO was used. Consequently, also doesn't report cannulation strategy, so whether peripheral or central VA ECMO, or the type of shock that patients were experiencing, whether distributive or cardiogenic, or a combination of the two. So the table here shows the top 5 medications or drug classes that were responsible for single substance poisoning cases. You can see that calcium channel blocker was the second most common agent in this single substance cases. You can see that for calcium channel blockers, the rate of survival was 77% with use of ECMO. Though I mentioned that this does not report specifically what form of ECMO is used to support, the assumption would be that predominantly VA ECMO was used to support these patients with calcium channel blocker poisoning. Elsewhere in the study, they report on both combined single substance use and combined substances, so where there was more than one agent that was used in toxic doses, and ECMO outcomes as such. There were 407 cases, and then 285 of those survived, with a 70% survival rate. The second study on the right here is a study looking at specifically the ELSO database, so the Extracorporeal Life Support Organization database, which is an international registry, and looking at VA ECMO support for drug-induced cardiogenic shock. This reported outcomes, and you can see that cardiovascular agents were the primary cause of most poisonings. There was a total of 104 cases, and then 49 of those cases were from a cardiovascular agent, amongst other things. Survival in this to discharge was 59.2%. You can also note at the bottom of the table here that there was a large number of patients who prior to ECMO experienced a cardiac arrest, which would be considered ECPR if ECMO is deployed in the setting of an active arrest. In comparing this to ELSO benchmark data, I've included those numbers on the bottom of the screen. So for VA ECMO support for cardiac failure, benchmark ELSO survival to discharge would be 48%, and in ECPR, when ECMO is utilized in ECPR setting, a 32% rate of survival to discharge. So you can observe that the rates of survival for the two studies, registry studies above, are higher than these benchmark data. And I think there's a couple reasons why that potentially may be the case. Next slide, so you can see that these are a couple different rationales for why ECMO may be a greater benefit to patients with poisoning compared to those who are put on ECMO for non-poison related either cardiac or respiratory support. One relative thing is fewer comorbidities for patients who are put on ECMO than benchmark patients. So for benchmark patients, the primary reason why a patient may be put on VA ECMO would be for myocardial dysfunction, most commonly related to cardiogenic shock from myocardial infarction. So in the case of somebody who has plaque rupture and then myocardial infarction. For those patients, they generally have higher comorbidities than patients who would experience an acute poisoning that's an acute toxicity, not a chronic thing. So oftentimes patients with myocardial infarction may have higher rates of things like diabetes, dyslipidemia, et cetera, that may lead to worse outcomes for their ECMO run overall. Also, these ECMO runs that are for drug toxicity are generally short runs. So in one study, the median time on ECMO support was 68 hours. Compare that to other types of ECMO support, which may be much longer, which obviously a much longer ECMO run is going to predispose to some of the downside consequences, such as bleeding or infection, that may come with ECMO support. ECMO can also be utilized to support a patient, the circulatory system or respiratory system, until a definitive antidote can either be obtained or administered, such as would be the case with Digifab for digoxin toxicity. If a patient experienced dig toxicity but didn't have a readily available antidote, then ECMO could be used as supportive agent to be able to support the circulatory system until that reversal agent could be used, or until the myocardium or respiratory system and other toxicities would be able to recover from an acute insult. Also, VA ECMO or VV ECMO support would allow for time for drug clearance, and then again with the hope of recovery of the underlying organ dysfunction, so that the patient would then be able to be bridged off of ECMO support, hopefully back to just native functioning organ, and be able to come off ECMO within a matter of days for the majority of cases that have been reviewed. I think patient selection is also a really difficult thing to determine for these patients. It certainly requires multidisciplinary care amongst several different disciplines and areas. For some centers that are used to cannulating VA ECMO in the ED, it could be done in the ED, but many other disciplines are usually involved in these types of cases. This study that I presented here on the left side of the screen is a single center retrospective study from France. They designed this study to be able to investigate factors that were associated with ECMO mortality prior to ECMO initiation. So in the cases here, a large number of these were cardiovascular poisonings. You can see approximately 80 to 90% of these patients were from a cardiovascular agent as the primary reason for needing ECMO support. And then approximately half of these patients experienced refractory cardiac arrest that led to ECMO initiation. So generally, survival rate would be predicted to be relatively low for these patients based on ELSO benchmark. In this study, overall survival rate was 47%. So this appears to be more consistent with ELSO benchmarks, though still greater than what ELSO would be predicting for the vast cohort of these patients. Two factors that in this study they found to be most predictive of mortality at ECMO initiation were a lactate greater than 9 and SAVE score. SAVE score is used, it was developed by ELSO, the Extracorporeal Life Support Organization, and is a tool that they have readily available on their website that looks at predicted mortality and predicted survival in patients based on underlying disease states or presentation at the time of ECMO initiation. You can see on the right side of the screen, this is how the format on ELSO's website looks, where you'd be able to select what the initial diagnosis, age, weight, what other comorbid things are going on with the patient or other situations that may be going on with the patient, to be able to then come up with a patient-specific SAVE score. This was developed and has been validated in VA ECMO support for adult cardiogenic shock. So based on SAVE score, it will then create a category, which you can see in the shaded boxes, and predicted survival based on SAVE score. A class 5 would be considered to be the lowest survival rate based on SAVE score, and class 1, the highest survival rate. And so the study on the left, going back to the study on the left, they looked at class 2 and 3 SAVE score at the time of ECMO initiation. And based on SAVE score, these patients who had class 2 or 3 would be predicted to have a survival rate of 42 to 58%. However, they found that all patients who had class 2 or 3, all of those patients survived. Granted, a relatively low number of patients, 8 out of the 8 patients who were put on VA ECMO support with class 2 or 3 SAVE score. For class 4 or 5 score, this would be anticipated to have a survival rate of 18 to 30% based on SAVE score and cardiogenic shock validation studies. In this study, they found that that survival rate to be 14% for this category. I'm going to turn it back over to Will for a little bit more about our case.
Yeah, thanks, Tim. I've actually heard Tim, share a lot of this data with us a couple times, really in preparation for this talk. And before I get back to the case, I think there's something I want to highlight is really that NPDS data that Tim was talking about a couple of slides ago. That is really coming out of the toxicology world. And a lot of medical toxicologists like myself and clinical toxicologists like Jess, I don't think we understand enough about ECMO to be asking a lot of the tough questions, when we're making these databases and when we're collecting them through the National Poison Data Set. Absolutely want to emphasize what Tim was mentioning is that we're not collecting data about VA versus VV, types of shock, or really even how we're cannulating the person to get on the circuit. And I think it's been a huge limitations, and particularly a lot of the toxicology databases to date, which in some ways is almost why we're, I don't want to say driving blind, but there's a lot of work that needs to be done in this field. And I really think it emphasized nicely how Tim sort of presented it. But if we could move on back to the case, and if everyone remembers where we sort of left off, is this very sick person, sort of refractory shock, going into oliguric renal failure, quickly developing anuric renal failure, and point of care ultrasound has this left ventricular function. Well, what happened with this person in particular is overnight on a hospital day 2, is her sister actually was able to get access to her smartphone and actually found a video of her ingesting 30 tabs of amlodipine. And this is where it became, I think, very apparent to everyone taking care of her, particularly the sort of pediatric sort of intensivist, that, hey, this is actually a massive amlodipine ingestion, and one of the reasons why we're having all this refractory shock. And then so over the course of really sort of that night, so this is really hospital day 2.5 going into hospital day 3, despite sort of very aggressive vasopressor therapy, continue to sort of decompensate particular hemodynamics. We even said, hey, we're going to tolerate, try to titrate for MAP goals, around 50 millimeters of mercury instead of 60. Was giving a lot of the rescue therapies that Jess mentioned early in the slide, such as methylene blue, epinephrine, phenylephrine, multiple vasopressors, particularly calcium boluses. And at this point, switch over from oliguric renal failure now to strict anuric renal failure. In fact, was about to get a dialysis catheter put in place. Strangely, the lactates, she came with a lactate of 8, but really on hospital day 2 had really normalized despite sort of really severe shock. But her ventilator requirements continued to worsen. And now her chest x-ray, felt chest x-ray shows these like bibasilar infiltrates. And that anasarca that I mentioned before, just all that edema, that pre-tibial edema, the periorbital edema, really continued to worsen. And this was actually a very fascinating now conversation, I think, that happened really about 7 a.m. With the pediatric intensivist. And some of them I think are Dr. Ruhlman, Dr. Lane, Dr. Moore, and Dr. Cardenas are, I think, actually audience members here. And some really fascinating discussions, I think, at the bedside about, what's the next step. And this is someone that, we think is just in fulminant distributive shock, but just not responding to sort of our standard therapies. And so we went ahead and actually gave a rescue dose of lipids. At that point, the pediatric ICU had re-engaged the ECMO team. And the decision was actually made, hey, she's not responding to any of our other therapies. We know this is very much a vasoplegic shock. Point of care ultrasound still very much show this hyperdynamic left ventricular function, but she is actively dying in front of us despite a very aggressive, really several days of resuscitation. So actually that morning of hospital day 3, she was actually taken to emergently to our operating room, essentially cannulated for VA ECMO. And what was really fascinating, I think, it was what her course was over the next 24 hours. Because when she got up to the cardiovascular intensive care unit, is her renal function, which I kept emphasizing had been declining so precipitously over the last couple of days, she immediately started making urine. In fact, never required CRT. Her oxygenation status on her, as evidenced by, I think, vent requirements, and also on our chest x-ray, we started seeing sort of improvement on infiltrates. And really over the first 24 hours, still actually required, ongoing vasopressor therapy in addition to being on the circuit. But when we were, again, looking at the respiratory findings and renal findings, looked like that, we're having much better end organ perfusion. And now, using our standard vasopressor therapy as well as being essentially cannulated on the circuit, we're actually able to meet those minimum MAP goals of 60 millimeters of mercury. And so this has actually got published by Dr. Cardenas earlier this year, really looking at this case. This is specifically already published about this case. And this was actually, I think, a very nice visual graph of looking at sort of the vasoactive sort of requirements that were required. So even though that we still required sort of vasopressor therapy over the next 24 hours, as you clearly see, once ECMO was started, had dramatic improvement. And I think that's why he actually got a lot of positive feedback when he had previously presented this information. And so what happened over the next couple of days? Well, the good news is she got better. Still, 2 days after being on the circuit, still required vasopressors, but each day, definite improvement with weaning vasopressors. Hospital day 5, she actually tolerated a clamp trial, and at hospital day 6, she was successfully decannulated. What's great about this case is, you always wonder, well, what's the long-term follow-up? Because, she left the hospital, went to psychiatry completely neurologically intact. Well, I'm actually very happy to report that about a month and a half after all this happened, she actually checked back into our pediatric ED. She came back in with chest pain. And thankfully, her chest pain was not necessarily cardiac related. It was actually still just some ongoing irritation sort of where her sternotomy site was. So it was actually pretty incredible for me because we got this sort of, month and a half follow-up where we were still able to say, hey, still neurologically intact, still has, intact CNS function. And frankly, it was sort of fun seeing her. They actually called me when she was there. So I went down to meet her, and, very different than the person that I had remembered seeing on this clamp, or excuse me, on the circuit. And so this case has been a really central case in my mind because, as a medical toxicologist, is going again back to the sort of limitation of the NPA's data, is for this case, I just didn't know to ask the questions that I think that we need to start posing and trying to figure out what is the role with ongoing sort of ECMO, particularly with calcium channel blocker antagonist. And I would encourage everyone here to actually, I think you need to do, or medical toxicologists need to do better partnerships because I learned so much just from this very much interdisciplinary sort of interaction. And one of the things I want to go ahead and sort of throw back to Tim, sort of one of our resident ECMO experts here, is what do you think is the role of ECMO in distributive shock? I feel like for so long I've been told, hey, we don't like to do it, particularly in adult populations. But it seemed here that we actually had, a very positive sort of response to it. And so, Tim, I'd love to get your thoughts.
Yeah. So it's really interesting for this case that it appears to be distributive shock, and based on point of care ultrasound echo findings showing hyperdynamic LV at one point. But based on the temporal relationship of improvement with ECMO and just the rapid improvement, it seems like there's maybe more that's going on with this patient. In an adult patient population, there was a systematic review that was published a year or two ago that looked at VA ECMO support in septic shock patients. And this systematic review showed that for septic shock patients, those who had an EF less than 20% actually had a better survival rate than those that were put on VA ECMO for septic shock who had an EF greater than 35%. So I think that going to show that ECMO support, somebody who has an EF less than 20% with septic shock really is helping to support largely the heart restoring organ perfusion. But somebody who has an EF that's greater than 30%, who is purely just distributive shock, that those patients have a much, much higher mortality rate than those with impaired EF. So for this case, I think it begs the question whether there was maybe some unrecognized cardiogenic shock. You mentioned physical exam findings that were present, so peripheral edema, significantly pulmonary edema. So I wonder about maybe not left ventricular dysfunction, but right ventricular dysfunction for this patient, if that could have been the case, because VA ECMO support will support right ventricular failure as well as left ventricular failure. So that's one maybe, I don't know, maybe unifying diagnosis maybe, but is definitely purely not cardiogenic shock since the patient still remained on vasopressors, and it wasn't like vasopressor requirement just went away right after ECMO initiation. So it appears to be maybe a mixed type of picture possibly for this.
Yeah, Tim, and I definitely want to follow up with that because, that was, I think, definitely one of the salient points about this case is because we were seeing this very hyperdynamic left ventricular function, but clinically absolutely had signs of right ventricular failure, right heart failure, with that massive pulmonary edema, sort of that ARDS type of picture, which is probably a mixture both of cardiogenic and non-cardiogenic pulmonary edema. But just I think the massive sort of fluid overload as well. And something else that came in sort of our bedside discussions is, also is this mimicking sort of high output heart failure as well. I think the lactate actually normalizing on hospital day 2, despite the fact that the patient was so shocky, is something that is seen with, high output heart failure, and there's the heart just working so hard to oxygenate. But basically it's just sort of having impaired diastolic filling times as well that goes along with it. And maybe even though we are seeing this, very hyperdynamic, with the left ventricular myocytes, is, putting a circuit actually gave the heart, almost some time to relax. Certainly, I think those of us at the bedside, certainly saw a definitely positive improvement. Another question we get, quite a bit is, once we do transition someone, with this very aggressive resuscitation and some antidotal therapies to putting them on the circuit, is what's the role to continue a lot of these therapies? And Jess, you saw that, we had methylene blue going, calcium plus multiple vasopressors. And sort of what's your thought process on this of who do we keep going? Or what do we keep going?
That's a really good question. And an interesting one, because actually we had a separate calcium channel blocker overdose case recently where the question of whether to continue high dose insulin once cannulated and hooked up to the ECMO circuit was necessary. Now, in that case, we were treating a non-dihydropyridine calcium channel blocker, which we know is going to have primarily myocardial effects. And so really the answer there is, as far as continuing high dose insulin or some of these more niche antidotes, if you will, you certainly want to continue it even while on the ECMO circuit if there's evidence of impaired LV function. So certainly in the cases of non-dihydropyridine cardiotoxicity, or if you have, again, somewhat of this kind of mixed shock state with perhaps a dihydropyridine once some of that receptor selectivity is lost. So any patient that you're initiating on high-dose insulin, again, primarily for that inotropic support, you should continue that therapy while on ECMO if that inotropic support is necessary. And one of the main reasons for that, and I think Tim did such a good job kind of reviewing this, is to remember, particularly with peripheral cannulation, which is the main cannulation we're probably going to see in our adult population at least, is the circuit is actually providing a retrograde flow. And so that is a lot of pressure and afterload that LV is kind of having to work against. And if the native, circulatory system is not quite at a place to actually ensure that aortic valve is opening, what's going to happen is you're just going to kind of back things up into the RV and furthermore and cause more problems with volume overload and things of that sort. And so you really want to offload that LV as much as possible and support it as much as possible while on the ECMO circuit in those patients who are showing evidence of cardiogenic shock or some degree of LV dysfunction. So Tim, I'd love for you to fill in any gaps there or expand further on that. And also perhaps discuss even continuation of other rescue therapies such as lipids. I know in this case, this patient did receive a dose of rescue lipids, and we get that question a lot of just, what does this stuff interfere with? So any experience there with ECMO circuits?
Yeah, I'll expand a little bit more first on just the increase in afterload with peripheral VA ECMO. So this is something that we talk about very frequently in our rounds for our ECMO patients, our VA ECMO patients. As Jess mentioned and summarized, peripheral VA ECMO is going to increase afterload for the LV. So it actually works against the recovering myocardium because it's more force, more resistance that the LV has to push against. So one thing we talk about consistently is LV venting and whether that's necessary or not. If there's such a high resistance and such a weak myocardium that the aortic valve is not opening, then it's just going to further distend the LV, which is then going to create more pulmonary edema. So while somebody may go on ECMO, VA ECMO with normal lungs and normal gas exchange, that potentially could become impaired over the course of the first several days if the LV is not properly vented. And so, like you mentioned, Jess, if there's inotropes or other medications that will be helping to increase LV contractility to help unload the LV and allow the aortic valve to open with every beat and create a good pulse pressure, then that would be evidence that the LV is hopefully being unloaded well. For a lot of our VA ECMO patients as well, they may have either Swan-Ganz catheter or at least a central line where we're trending CVP or PA pressures for recognition of if somebody is not adequately unloading the LV in those patients. For the second part of your question about intralipid, yeah, I think that's something that's a concern for a lot of people with ECMO is whether lipid-based medications will result in ECMO circuit failure. And I think the choice of whether to initiate ECMO in somebody who's got lipids or lipids in somebody who's on ECMO is sort of center specific. I think if there's a consideration for ECMO and kind of going down that route, I would probably hesitate to give lipids right away at that point. The concern would be that with lipids that it may cause oxygenator failure due to agglutination of lipids in the oxygenator. If oxygenator fails, then that's going to be inadequate gas exchange. So for example, for a peripheral VA ECMO patient, if there's inadequate gas exchange that's occurring in the circuit, then you're going to be potentially depositing either deoxygenated blood from the venous system into the arterial system or lack of CO2 removal into the arterial system, or just complete circuit failure. So for high volume centers that are very used to having ECMO patients, then circuit changes can occur very rapidly. And so there's, in my mind at least, less of a concern with using lipids or initiating ECMO in somebody who's received lipids, because if there is failure, then a circuit change can be performed in relatively a matter of seconds for experienced centers. But for lower volume centers that aren't used to performing exchanges quickly, then that could delay time on ECMO support and delay time to circuit change, and then could also result in more stasis in the circuit if that has failed, which then could lead to clot formation and then further dysfunction of the ECMO circuit. So I would not withhold ECMO from a patient who has gotten lipids, and there's been several case studies. The majority have been with getting lipids first and then going on to ECMO, but it is there's maybe one or two that I saw of patients who got lipids on ECMO support already. But we have a lot of experience with giving propofol, TPN, other lipid-based things in ECMO, but with just such a large volume, that would be the concern with lipids.
Thanks, that's awesome, Tim. And that really enlightened us as you kind of walked us through that, because I know Will and I talk about this a lot, you know, when we're performing as consultants through the Poison Center and maybe don't have the luxury of being at the bedside or, you know, an ECMO expert next to us. It helps remind us and prompt us to ask some of those important questions about, you know, what resources the center may have as it pertains to ECMO and how quickly they can change oxygenators out, et cetera. Any final thoughts on maybe central versus peripheral cannulation? This was also a topic that was fascinating to me, and you taught me a ton on, and again, gives me like extra questions to ask when I am considering you know, recommending that a team consult the ECMO service.
Yeah, so all of the things that I mentioned with increasing afterload for the LV and peripheral VA ECMO, that's not really the case for central VA ECMO. So for central VA ECMO, I didn't include a picture of it, but would be pulling blood from the right atrium and then generally outflow of blood to the ascending aorta. And so blood would be flowing in the antegrade direction of flow for the circulatory system of how it normally would function. So there's not that increased resistance that the LV has to push against. The same thing is true about still making sure that the LV is unloaded, that you have pulse pressure to ensure that there's not hemostasis in the LV, which could predispose to clot and then eventually to stroke if that is dislodged. And so I think the point still remains that patients who are on central ECMO should still make sure that they have pulse pressure or unloading the left side of the heart. But there's not that increase in afterload. In the adult population, like you mentioned, that's probably going to be what the majority of people see as the initial form of VA ECMO, because access to vein and artery for cannulation is so much faster, especially within an ECPR setting. And so central in the adult population is typically just used in patients who are post-cardiotomy, who already have the sternum open, and then are have access to central vessels at that point right away. But yeah, there's not the same afterload concern with central ECMO.
Great. Well, thank you both so much for kind of that fruitful discussion. We have a couple minutes left, so we'd love to just quickly turn it over to the audience. We really thank you all for your attention, just to see if there might be a question or two. Certainly, we'd love for anyone to reach out if you think of a question later, or if you just have an interesting case you want to discuss or collaborate on something. We've included our email addresses there on the slide. So please feel free to reach out to any of us, but we will turn it over to the audience or Nick if you have any last minute questions for us.
Awesome, thank you guys. Please put your questions in the chat or the question tab. Let me see, let me make sure I'm not missing anybody just yet. I don't see anything at the moment. Hopefully, please type them in there. Someone said fantastic. Someone asked, will the slides be available? So just to remind everybody, we generally don't send out the slides, but we do post this on our YouTube. So you'll be able to watch the presentation there. If you had someone that unfortunately wasn't able to make it today and they want to listen in, they're definitely available to do that as well. I've got one here that says, I don't know if you guys can read this or not, but the study that you referenced regarding VA outcomes in the adult population with the EF of less than 20%, was that primarily peripheral VA ECMO?
Yes, that was predominantly peripheral VA ECMO, not central VA ECMO for those patients. And like I mentioned, just to recap, ECMO or survival rate was lower in the patients who had an EF greater than 35%. Compared to those who had an EF less than 20%. So EF less than 20% actually had better survival for peripheral VA ECMO in the setting of septic shock.
Awesome. If anybody else wants another one, please put it in. I'm going to ask one. We actually, a couple of years ago, ended up putting somebody on Mars for an amlodipine overdose. What are you guys' thoughts or any experience with the use of Mars for hepatically cleared medications for overdose?
I think Mars is even a bigger question mark in the tox world than sort of ECMO is. Obviously, Mars is incredibly center dependent. It's not a capability that we actually have at our academic institution. I think it makes sense if you have a ongoing hepatic dysfunction. I will say a lot of times is, particularly the calcium channel blockers, is clearly a multi-system organ failure. Usually, though, we actually see that the hepatic system is still intact. But certainly, if we got, if you have Mars available, amlodipine incredibly, highly hepatically metabolized, and you had sort of severe sort of synthetic, I think, hepatic dysfunction, you could consider it. In the toxicology world, I'd be more, I think, interested to see sort of the role of Mars in the future, really with these specific hepatic toxins, acetaminophen being the most common one, but Amanita phalloides, death cap mushrooms, will be something else that might be in the future for Mars therapy. But right now, it's not one of the sort of central tenets, I think, of our approach.
Yeah, I would add as well that oftentimes if a patient has a prolonged period of time, either hypotensive or with either distributive or cardiogenic shock, that there may be that kind of initial elevation in LFTs, which with restoration of perfusion may resolve in a rather rapid case or sequence, such as the case with, in this case here, renal dysfunction with resolution very, very rapidly. So unless there is hepatic failure, but if it's just hepatic dysfunction from poor perfusion, then hopefully restoration of perfusion would resolve that.
I've got one comment coming in. These cases make me wonder if additional support with central cannulation and ECMO for CI of greater than 3 liters per meter square in patients with primary distributive shock may allow better outcomes. Any thoughts on that?
I will definitely respond. This is actually coming from Dr. Moore, who's taught me a lot about central cannulation, and I think Dr. Moore, a lot of work needs to be done with it. But right now, it certainly seems in the patient populations that we've had that this central cannulation, particularly in these adolescents, is we're getting better outcomes, even better outcomes than what Tim was sort of reporting in the NPDS data, and then the other John Cole, Minnesota study that he presented as well. So obviously, like everything, there's more work to be done with it, but I think our experience is certainly trending in that direction.
Any other questions, comments from anybody? One that we had here at our campus was, what do you guys think is kind of an ideal methylene blue dose in someone like this? I think you guys said a methylene blue infusion, but I feel like there's so much literature all over the place for different indications. What are your dosing strategies in someone like this?
I think we're also all over the place as well. To be perfectly frank, is often we're usually starting with a 2 mg per kg or 1 to 2 mg per kg, usually 2 mg per kg sort of rescue bolus, and then starting sort of, if we think that we're seeing sort of a positive response with that, then we're starting the infusion. But I think at least usually we're starting with, again, that 1 to 2 mg per kg a bolus, and then figuring out sort of infusion rates after that. But I feel like we've also been have a lot of heterogeneity in our approach as well.
Yeah, I think my approach as well, in the not for a drug toxicity perspective, but in a post-cardiogenic shock vasoplegic patient, post cardiac surgery vasoplegic patient, is initially bolusing 1 to 2 and seeing if they respond to methylene blue, because we've had a number of patients who have really inadequate response or very little increase in blood pressure following methylene blue bolus. And so for those patients, I don't think it makes a whole lot of sense to then continue on an infusion for something that hasn't showed any benefit in that patient. So that I would think would be applicable to this as well. But then considering other therapies, so Will mentioned earlier hydroxycobalamin, angiotensin II just mentioned as well. So consideration for other things if you don't have kind of early response with methylene blue.
I have not seen any other questions from the group. Thank you guys so much for coming and talking to everybody today, and thank everybody in the audience for joining us. We'll have our next bite-sized lecture here in a few months, so be looking out for those emails, hopefully to have some continued very interesting cases and great speakers for you guys. Thank you guys so much, and everybody have a great day.
Thank you.